Campus Principal, Professor Rosemary Bell Antoine, Deputy Campus Principal, Professor Derek Chady, and other members of the campus executive management team. Professor Risha Rafiq, our featured speaker and Professor of Restorative Dentistry. President of the Trinidad and Tobago Dental Association, Dr. Sanjay Ramnanan. Chairman of the Dental Council of Trinidad and Tobago, Dr. Dharmendra Rohit. Faculty deans, heads of department of the UWI St. Augustine campus, staff and students of the UWI St. Augustine campus, friends and family of Professor Rafiq, our specially invited guests and members of the media. Good evening, ladies and gentlemen. I am Professor Shirin Hack, Chair of the Open Lectures Committee here at UWI St. Augustine, and for this evening session by Professor of Restorative Dentistry by Professor Risha Rafiq. This lecture is our last one for this academic year, and I'm sure one which will leave you with a smile, all right? We are extremely pleased and excited to host you this evening. In our lecture series this year, we have seen the impact and inroads the UWI has made internationally, regionally, and locally with its researchers who have reached the pinnacle of success, the League of Professors. Today's topic impacts each and every one of us personally. The role of the Open Lectures Committee is to host professorial inaugural lectures to showcase the research and work of the campus's recently appointed or promoted professors. Such dedication and intellectual prowess is what makes the world a better place. Furthermore, the role of this committee is also to advance the university's knowledge transfer agenda via high-quality open lectures by exceptional local, regional, and international speakers. And Nobel laureates and heads of states have graced these stages in the past. These lectures are therefore just one of the platforms that our campus uses to engage the wider national community on issues relevant to local and regional development, impact regional policy making, analysis and evaluation, and, of course, stimulate and encourage the pursuit of excellence. So be sure to follow the UWI St. Augustine Facebook page, where you will see information on upcoming events. At this point, I would like to invite Professor Rose Bell Antoine, Campus Principal, St. Augustine Campus, to deliver the opening remarks. Let us welcome her to the stage.
Good evening, everyone. And Chair, thank you so much for the wonderful work you continue to do. But I want to especially welcome, although we've had all these salutations, I do want to especially welcome Professor Rafiq and, and her entire family. So welcome to this wonderful event. It's a little rainy, but still a special evening for all of us. And I do have the pleasure to continue to welcome you to this inaugural professorial lecture. She's also a deputy dean, as you heard, and that's no mean feat, by the way. Having to do administrative work is tough in this university, as I'm sure you all saw this week. And then to continue to research and publish, I think we need to give her another round of You know, some people bury their noses in their do the research, but when we have people who are giving and still publishing and demonstrating their commitment to the university, I think that is so wonderful. So we are here to celebrate Professor Rafiq's significant milestone in her career, and she's certainly no stranger to accolades. In fact, she made history by becoming the first female professor of dentistry at the University of the West Indies, St. Augustine. And additionally, she was awarded a fellowship in dental surgery by the Royal College of Surgeons of Edinburgh in 2024. And in 2023, she was elected a fellow of the College of General Dentistry in the UK. So congrats again, Professor Rafiq. Lots of applause. You have had a really impressive career, training over 500 dentists since the first graduating class of the UWI St. Augustine School of Dentistry in 1994. And this career is not confined to undergraduate training, but also includes extensive publications in international and regional journals, as well as participation in numerous presentations at international research conferences. As you can see, as our chair said, the UWI St. Augustine continues to attract the best and brightest in their fields, despite our relatively low salaries. Shh, I didn't say that. Right. However, let me say we are not just a teaching university. We are also known for groundbreaking research. In fact, that's our strength, a research university. And Prof. Rafiq, when they become professor, we say prof. We don't just say professor. It's a term of endearment. Not so, Dean? Exactly. So she's one of our key contributors in this quest towards groundbreaking research. Her research encompasses crucial work in the field of dentistry, such as clinical, restorative, dental techniques, and oral rehabilitation. And in keeping with the tradition of scholars from the UWI, her contributions have significantly impacted society, both locally and regionally. And I can say as principal, one of my best outings was when I visited the School of Dentistry to see the work that you all are doing with the community, the pro bono work, that clinic that you all do. It was really quite wonderful. I was very impressed with all that's happening in that School of Dentistry. She has left an indelible mark on the landscape of medical education by serving on several national boards as well as lecturing across many CARICOM countries. And she continues to give back to society by currently serving as the Regional Vice President of the Commonwealth Dental Association for the Caribbean and Canada. I have no doubt that she will continue to make us proud. I see some of your dental students coming in now, probably just had a class, elevating her field in the process. And incidentally, I think it's a special pleasure to host, Faculty of Medical Sciences, because often, we talk about, kind of far away. So it's good that we can all come together at this forum and you be part of us. You're always part of us, but because of the location, I think it's an extra special event to have a professor from the Faculty of Medical Sciences in our midst here today speaking to us. And so this lecture, as she continues to elevate her profession and continues to elevate the university, because we live and we become famous and we do get world rankings and all of that because of the work. Persons like Prof. Rafiq, all of our professors and our excellent researchers, that is how we are put on the map. And that's also how we contribute and continue to contribute so much to regional and national development and beyond. It's through the research and this kind of work. And in this lecture, she will take us through the strategies and materials used to restore a patient's dentition to aesthetics, form, and functionality. Quite a mouthful, no pun intended. Well, actually, pun was intended. Dental care in the Caribbean is an area in which there has been a paucity of research, which Professor Rafiq's work aims to address. Her lecture will include her own personal journey, as well as the research findings she obtained, which involve the presentation and management of dental issues such as tooth decay. The lecture will not only touch on clinical restorative techniques, used in the oral rehabilitation of worn dentition, but also the management of patients with severe tooth defects using restorations such as crowns, bridges, and dentures. And while this may seem impressive, we at the UWI take great pride in our innovative, cutting-edge work, and this field is no different. Professor Rafiq's lecture will also involve taking us through the evolving arena of digital dentistry and its impact on the field. And I'm sure the dental practitioners here today, as well as the current students, will be particularly interested in that. In fact, I think I agree that everyone is interested in dentistry in some way or other. It's really something that touches all of us. Anybody who's ever had a toothache, as people say, you can only experience it. You can't read about it. It's something that is so traumatic. So we really need our dentists just as much as we need our doctors and all the others. Overall, I believe this lecture is really very important and of interest to all, and I think the attendance demonstrates that despite the weather. And I think we now accept that dental health is a core aspect of overall health. And so this means that oral hygiene and practices are vital to our general health. And this makes the work of our scholars, such as Professor Rafiq, even more critical. I hope then that the policy practitioners here today embrace the insights that will be shared and advocate for a more integrated approach to health that includes dental care as a fundamental component. And we're going to talk a bit about that, Prof. I just want to close, as always, by acknowledging the work of the chair and the committee, Professor Hack, who is also a pioneering woman in her own right, not just the first, but the only woman professor of astronomy in the region. I'm always boasting. And she has a wonderful team, which includes marketing, which includes DFM, which includes a whole host of persons who work really hard to put on this very special event. So thank you to your team and all of you. I welcome you to this wonderful lecture.
Thank you, Professor Antoine. I just love listening to our principal. Lots of fun, very inspiring. So I will now like to invite Professor Hariharan Sitaraman, the Dean of the Faculty of Medical Sciences, to introduce our speaker. Please welcome him to the stage.
Good evening, ladies and gentlemen. When you come second after an eloquent speaker such as the principal, Professor Rosemary Antoine, who took all my words, I think she read my mind, and I don't have much left. I don't have much left to say, but still I will attempt to say something, because I thought at least she will spare me the tooth pain part of it. Being an anesthesiologist, she took that too. Because I was always wondering in my career as anesthesiologist, why dentists were trying to find discover anesthetics those days in the 18th century. Because dental pain is one of the worst pain. And that is why they wanted to, I'm scared of dentists. I have to say that, because my wisdom refused to part with me. And, the dentist put me on the dental chair, and then two people were retracting my mouth. One Sardarji with a turban, and I was like, even now I get nightmares with that. So they gave local anesthetic, and the wisdom refused to part with me. So they cut the bone mandible and tried to take. And then when I came to uh, Trinidad, and then I went and checked for my, and then the wisdom is still there with me after all that. But the bottom line was I couldn't open my mouth for like 2 weeks. It was terrific pain. It's not a bad thing, yes. My wife would have liked it. So I'm extremely delighted and privileged to introduce Prof. Risha Rafiq to this smiling audience. To start with, I want to describe you the process of reaching this pinnacle of academic achievement as a professor at the University of the West Indies. Professorial position at the University of West Indies is exclusively academic merit-based and is not a time-bound promotion as it exists in many other institutions. I mean, many other countries, once you reach 20, 15 years in your, as a teaching staff, you are eligible for a professor. They don't look at your CV and stuff like that. It's time bound, but it's in the university in the University of West Indies. It is exclusively merit based. So after lecturer and senior lecturer positions and crossing the merit bar at each level, an academic staff member applies for the position. When they reach a remarkable level of their academic research and scholarly output, then this application goes through multiple levels of scrutiny by a senior management team, including campus principals, PVCs, university registrar, vice chancellor, and then sent to 3 external reviewers to assess the strength of the scholarly output of the professor, including citations of their work by other researchers. So the candidate is assessed in multiple dimensions. One is the scholarly output as evidenced by the original distinguished work, evaluated by 3 external assessors, teaching and learning, and contributions to the university as well as the nation. So I'm very proud to say Prof. Rafiq has excelled in all these 3 dimensions, and she is the first and the only female professor of restorative dentistry in the region in the university. So I don't want to go into the details of academic qualifications, but Prof. Antoine already alluded to some. She did her basic Bachelor of Dental Surgery at Guy's Hospital at University of London and obtained a certificate of implant dentistry and master's with distinction in conservative dentistry, both from Eastman Dental Institute at the University of London. Then she went ahead and received her fellowships from the Royal College of Surgeons of England as well as Edinburgh. So Prof. Rafiq has been active in her research and publication throughout her tenure. There are 6 publications in peer-reviewed journals, book chapters, 16 published abstracts, and 26 conference presentations. Her H index is currently 15, ITIN index is 18, and 965 citations according to the Google Scholar. That means, these metrics show that, she has had some impactful research. Her research themes have centered around undergraduate dental education, dental material science, restorative dental techniques, and oral rehabilitation. And currently, more recently, she is actually working on the oral microbiome and its role in oral diseases, which is extremely important because oral microbiome now is being implicated in many diseases. So her particular area of research interest is restorative dentistry, which involves restoring the form, function, and aesthetics of the dental hard and soft tissues. So her research spanned across in vitro evaluation of dental materials, physical properties, in vivo clinical restorative techniques, and survival in the oral cavity, investigation of the oral microbiome and its link with periodontitis and dental caries, So her passion for teaching fueled her interest in educational research, and she has evaluated the teaching methodologies as well as student outcomes and performances in both clinical and preclinical settings using the multimedia. She is an editorial member of the Springer Nature publication journal Scientific Reports, which are very high impact factor of 4.6, which is the fifth most cited journal in the world. She also is currently a guest editor for a special collection of endodontic diagnosis and treatment with Scientific Reports. She has written a book chapter entitled Tooth Restoration with Crowns, Bridges, Veneers, and Implants as a part of the book Oral Health and Disease, What You Should Know, which is also published by Springer Nature. So she has been either primary investigator or co-investigator in 5 campus research and publication grants, which is actually very difficult to, within the campus community, you have a competition to source it. So, and 1 international grant from National Institute of Health, United States. She has presented her research papers in a number of regional and international scientific meetings, and she has been a facilitator for numerous local workshops and seminars. She has organized a number of collaborative meetings with UV and other institutions. Prof. Rafiq is the first examiner for 3 courses and teach on 8 courses. She has performed in the role of internal, first, and university examiners, and she examines in both preclinical and clinical phases. So during this time, she developed actually course booklets, laboratory manuals, and clinical manuals, which facilitated clinical services. Recently, she has been instrumental in the introduction of what we call as a OVO intraoral scanner, which is the latest technology in digital dentistry. So that has been introduced into restorative dentistry at the School of Dentistry. So, and this particular scanner, oral scanner, students, staffs, and patients can benefit from this new optical scanning unit, particularly crowns and bridges, and this can also be used as teaching aid in keeping with international best practice. So this is the evolving area in dental technology. Now, the student feedback for her teaching has always been positive because she teaches courses in both preclinical and clinical dentistry. She would have mentored, and principal mentioned, close to 500 dentists who are practicing in the country or and in the region. So, with respect to contributions to UV and the nation, Prof. Rafiq is the current Deputy Dean of Academic Advising and Outreach. And I must add that, she excels. She has an outstanding performance as a Deputy Dean, and she is so passionate about, being, not only academic advising, but also outreach. So, in addition, she has been a member of several university committees and contributed in many areas of curriculum development and administration. And Prof. Rafiq has multiple roles in the area of public service, all mentioned by our campus principal. And currently, she is the regional vice president of the Commonwealth Dental of Caribbean and Canada. So there are many other contributions, and in the interest of time and to listen from Prof. Rafiq herself, I want to summarize that Prof. Rafiq has clearly satisfied all the requirements to hold this sterling academic position of a professor at the University of the West Indies. The purpose of this lecture is to make the common public understand her research and the practical application of the research, so how it has impacted the nation, the region, and the world, and internationally. So, in summary, I feel extremely proud to introduce her and recognize her academic as well as other contributions, which she will highlight in today's lecture with a smile. Thank you.
I've started off. Good evening, everyone, ladies and gentlemen. I feel very, very humbled, actually, by the introductions I've received. Campus Principal, thank you so much. Professor Harry, Dean, Faculty Medical Sciences, thank you again. Very appreciate the words that you've exchanged with us tonight. Want to acknowledge Prof. Sarah, our Deputy Director, Graduate Studies and Research, and of course, Prof. Shireen Hack for organizing the event for us tonight. Thank you so much. Welcome, everyone, my family, my friends, the dental community. I see so many of you here, so many familiar faces, my colleagues from the Faculty of Medical Sciences as well, and my colleagues from all around UWI, and my ladies crew who keep me sane somewhere in the back, right? You know, doing all the things that we do. We need those persons supporting us. So very much appreciate you coming out. I know the weather's terrible, but we made it here finally, and if I can get my pointer to work. I just put this one up for another laugh and a smile. Those who know me well know I'm a big Spurs supporter, football and cricket. We won the cup. I put it up for my son. They arrived late. They were one of the latecomers. They were working in Port of Spain, and daughter. So we won. What's behind a smile? So many things behind a smile. And I think Prof already sort of gave a lot of my journey already and principle, but still, for tonight, I would like to actually just present the findings of my research that we've done at the School of Dentistry and really my journey through academia and illustrate that research through the journey. I'm going to give you a bit of background to the dental diseases as well and some of the other disorders that we see in restorative dentistry. And Prof already touched on the future prospects that we have with digital dentistry as well. So I will be touching on that and some challenges that actually happen with all the research that we've had. I'm gonna, I probably have to apologize a little bit. The lighting, we need to keep the lighting up, so some of the slides are not as perfectly crisp on my screen as you're seeing it. But what's behind a smile? We all want to have a lovely smile and good oral health. And the healthy smile is not only about having good oral health. When we have a patient like this who walks in to see us, 25-year-old, she came in, she was referred in to see me. She was in a lot of distress, a lot of issues going on with her. Teeth broken down, she was in a lot of pain. And what did that do? That really impacted her confidence, her well-being, her ability to speak and chew, and also her quality of life. So we have some real issues with patients coming in, and what can we do to really help them along their pathway? 25 years old, and she had 2 young children, and her mother was somebody who had lost all her teeth at a very young age. So she was really concerned that she was going to lose all her teeth as well. And we had to reassure her, look, we're going to do everything we can do, and let's work with us to find out what is possible. So I'll come back to this case later on in the presentation to show you. But it also affects your overall health, and I think Principal alluded to that connection now that we know that we have with overall health and your oral health. So I just want to give you a little bit of my journey before dentistry. I grew up not far from here, just in Curep, and some of you might recognize the mosque. So the St. Joseph TML primary school I went to, that mosque has a real close affection for me. I was always around it, and my father's father, I think, was one of the imams at the mosque as well. So I attended the primary school, and we were very lucky at that time to have grass all around the mosque. It's not paved out. Was able to play, pelt mango, you know, catch pui flowers falling from the trees, that sort of thing. Wonderful. We had a lovely pui season, but now that's all come with the rain. So very close by to the university. Again, I was very fortunate to be able to go to St. Augustine Girls High School. And somewhere out there, peeking out, you'll see me in my uniform. And I have some friends here from SAG, so we don't want to give our age away, but we had a 40-year reunion last year to tell you how long ago that was. Right, so I think being at SAGS, I had the privilege really of having somebody like Dr. Anna Mahes, who was our principal, and she really inspired us. She was a real icon of education. And she had us all feeling like, you know, no matter what we wanted to achieve, we could achieve it, even though we were girls, as she would call us, her girls. So I think that set me on a good foundation for moving forward with my my sort of journey that continued. Prof. Harry said that I had been able to go to University of London and do dentistry at United Medical and Dental Schools of Guy's and St. Thomas's at the time, and that became sort of morphed into King's College London. I literally had this picture up here. This is Guy's Tower, the Thames River. This literally is the tallest hospital in Europe, and I think in the world again. So I was so fortunate. I had London at my feet. We were working from floors 22 to 32, the dental school, and floors 1 to sort of 21 were actually the medical hospital. And it was such an experience that I suppose at the time, being a typical student, I didn't realize the type of lecturers and professors I had. As a student, you think, what do these people do all day? Just talk about teeth and lecture about teeth. I know the students know that. But really, I suppose at the end of the undergraduate degree, I was appreciating more the kind of level of professors that I had. And one was a female professor who lectured in the field of operative dentistry, what I do now. But at the time, the field was almost like doing tooth carpentry. I think some of the dentists would agree with me here in the audience. So it was not biologically driven, and it was very much mechanically driven. And she was sort of a pioneer in that field of dental decay. She was awarded the first professor of karyology in the UK. So I think that had a fair amount of influence on me, knowing that even though there were a lot of male counterparts in the department, she was able to sort of blaze her own trail as well. So that was quite an interesting time for me, but I have to tell you, I had no interest in academia other than getting my dental degree and getting out of school. I don't know if many of you feel like that, but you just want to get out and graduate and go get to work. So I was no different, certainly. And that was the sort of background to getting into dental caries. We call it dental decay. Proper word is dental caries, and we're all familiar with these cavities, and you may have an experience yourself with somebody else that you know. These are the main diseases that I would work in terms of restorative dentistry, so periodontal disease, which is gum disease, and edentulosum, which is essentially missing. There are many, many other dental diseases, but these are the ones I'm going to concentrate on that I work more in the evening. I have to say, when Prof. Hack asked me to do the lecture, maybe a lot of people, I was thinking, should I do it, should I not? Once I decided to do it, I got very excited. And I ended up with a huge amount of information, and I thought, gosh, they're not going to listen to me for 2 hours. So luckily, I've cut it down, and we're not going to spend 2 hours this evening here. The link with periodontal disease or gum disease and your oral health is quite an evolving one right now. So we know now that periodontal disease is linked to diabetes, and it's a bidirectional link. Before, we would know that diabetic patients would come in with a lot of gum disease. Now we know that actually having gum disease can influence your glycemic control, your blood sugar level. The link is also there for cardiovascular disease as well, particularly atherosclerosis. And there's also coming out now a lot more evidence to show there's a link with Alzheimer's. So that really influences now how we should be dealing with our patients. We shouldn't just have our patients isolated to dental surgeons and medical doctors. We really need to be talking together and referring our patients both ways to get the patient really best care. And we know periodontal disease is quite important. I work more in the area of, as I said, dental caries and dental cavities that are formed. So the global burden of disease study that was done showed that untreated dental caries was actually the most prevalent of all 291 conditions. So we want to emphasize really the importance of it. I know I have a lot of medical friends, doctors who are friends, and they say, you'll do all day, you'll just study teeth, no big thing. You take it out. But it is becoming more and more evident how important it is, and I really want to emphasize that and the quality of life that our patients have when they have good oral health. So what is dental decay? I mean, simply put, everybody sort of knows you have cavities. This is the big problem, your sugars. When we were trying to tell people to reduce your sugar intake to save your teeth, maybe it didn't have that much impact, but now we know how much impact sugar has on your general health as well. So the message is the same, public health message, to reduce sugar intake. But essentially, the decay on the teeth that we're going to have is due to the bacteria, certain bacteria, that are going to be intimately involved on the tooth in this biofilm that we call dental plaque. And when it sits there for a while, the bacteria actually metabolizes sugars and produces an acid. And that acid can actually cause demineralization of the tooth structure once that critical pH falls below what we call 5.5. Now, the good news is that it's actually able to remineralize. So we can do a lot in terms of prevention. And that remineralization can happen because of neutralization by saliva products. So if you have a good salivary flow, you can get it to remineralize. And also the influence of course, everybody knows about fluoride. If there's fluoride around, we can actually uptake the fluoride. So dental caries, as I said before, was thought of as a fairly simple disease, a sort of infectious disease because bacteria is involved and it could be transmitted. However, it's been developed now really to be reclassified as a non-communicable disease. So that's the main part that has changed. And why? Because there's so many other factors that are actually involved in the formation of dental caries, behavioral and psychosocial factors. So the disease management really falls under two big areas. And caries prevention, of course, you guys will be aware of your simple public health messages: oral hygiene, brushing, flossing, use of mouthwashes, use of fluoride, and pit and fissure sealants, and also the use of xylitol. So I'm going to highlight throughout my areas of research, and I'll come back to this one and the use of xylitol. In terms of the operative management, what do we do when we have these cavities already formed? And that's kind of where I've spent most of the bulk of my work and research. We all know about amalgam, silver fillings, but a lot of the tooth-colored materials were developed. So we have these things called composites. They are sort of resin matrix with particles inside, the glass animal cements, and those ones are really thought to be totally bonding to the tooth structure, so it's a big plus in terms of a dental material. And the huge benefit of that particular material is that it actually releases fluoride. So if you have a material that is sort of acting as a type of, in effect, a sponge, that when you pack it in, it's releasing fluoride continuously, you have a great benefit around it. So it's a material that a lot of work has gone on, and I've done research as well that I'll highlight. Pompomers were developed to try and get the best of both worlds, essentially. So these glass animals were not as aesthetic and not as strong as the composite material. So again, a lot of research in that. And of course, when things go really bad, I think Principal was talking about her toothache before. So the toothache could come, if it's really bad, we get down to the root canals when the nerves are infected and you get pain and infection. We need to actually clean it out. We do things called root canals. So again, I'll highlight some research that I've done in that area. And some of the advanced work will come along as we go through the presentation as well. So Prof. Harry spoke about, I think I was there since 1994. This is the pioneer class. Some of you might see yourselves, and you don't want to identify yourselves now, but really I was hiding in the back here. This gentleman was the director of the dental school, Prof. Prabhu, and this was Professor Sidney Haynes. He was a professor of orthodontics. And the only Trinidadians were myself, Dr. Sharma, and Dr. Scipio that we have there. And some of us will remember Professor Eric Thompson, maxillofacial surgeon as well. But I was not working in academia at all. I had actually come back home and had set up practice, and I was working in the RHA. And I just got a call out of the blue. I had applied to UE. I think my mother had told me, hey, there's a dental school that opened up. Why don't you apply? And that had happened like 6 months prior. And I never heard anything, never got acknowledgement. Suddenly I got a call to say, come in and have an interview. And I literally came in and met Prof. Prabhu and Prof. Haynes. And they said, okay, great, can you start Monday? I think that was a Wednesday. I don't know if that was legal practice in those days, but it literally was no panel, just hired. So I'm glad I'm worth it through the system, right? Hired as assistant lecturer. And again, I was not in the academic sort of role. I was really into my patients and the clinical work. And I thought, let me see if teaching is of any interest. And I found that I actually enjoyed it. So again, sometimes you have to thank your mother for suggesting things for you, and she's here tonight, right? The school had a lot of turnover of staff. So the dental school was really filled with a lot of visiting lecturers from the UK and the US. So for the students who were there, it was horrifying because they never had permanent staff. But for someone like myself, I actually benefited a lot. I met so many professors and experienced dentists. So I just soaked up everything. The staff finally got a little stabilized with persons from India, persons from the UK, Dr. Albayati, who everybody knows is a stalwart at the dental school. But I was assistant lecturer working with Professor Allen and an endodontist called Dr. Valley. I just want to point out, I do have a baby bump there, so the baby bump is out there in the second row 30 years later. So he made it and he said, do not put any naked baby pictures of me in your presentation. So at least I got it safe, right? So Dr. Valley was an endodontist, and she wanted to do research on a new kit that had come out. And the challenge in Trinidad is it's so difficult for us to develop new materials or develop new equipment. So we have to try and just do research when things actually get approved and come out. And she said, let's put in for a grant, campus research and publications grant. So we did. We developed the idea we wanted to do, and we worked on it. And a gentleman by the name of Prof. Walker was one of those visiting persons as well. So he came in just at the time when we were doing the research. I was what my good friend Christine Carrington would call assistant beaker. You're just helping people out, and you don't know what you're doing. So we were working on a study, and what we wanted to assess was the sealing ability of this root canal filling. So why is it important? If it's not sealing properly, we're going to get reinfection and micro leakage. So this is an x-ray of the tooth. This is the crown, the root of the tooth. The filling material here is all white and opaque, and we want to make sure that no bacteria can basically re-enter and cause reinfection. So a lot of time is spent on us in dentistry and dental materials evaluating leakage of materials and how well they seal. So we came up looking at a new technique that was offered on the market, which was a thermoplasticized one, so a heat one, and compared it to the regular standard root filling technique that we had, which was a cold condensation technique. So I was able to find all these extracted human teeth, clean them up, get them prepared, and have 2 experimental groups and some positive and negative control groups as well. And we were able to, through the fund, purchase the equipment, get them filled in, and then put the teeth into a dye so that we can measure leakage, and then go through a process that would actually make the teeth transparent and measure it under a microscope. So this is how we tested all leakage. And what we found in that particular one was that the obturation was found to be comparable, so that was actually a good thing, that the new technique and the old one were working well together. At the time with Prof. Walker, what all of us were looking at was just leakage in one area, the apical part, but he was the one who actually was speaking to us about the importance of, well, the dentist will appreciate the coronal leakage, the leakage at the crown, which is standard for us now, but at that time that was very new to be working on. So Prof. Walker was an influence at that point, because the second thing he told me was, it's okay to be working and teaching, but if you want to stay in academia, you have to go away and do postgraduate education. And we didn't have any postgraduate programs at the school. So he said, if I write you a reference, you're going to get into the Eastman Dental Institute, but you've got to agree to go. And I said, let me check into this, how much money it was. It's a huge amount of money. Again, the university has been so good to me. At the time, the university was trying to really stabilize teaching staff at the school. So they said they would sponsor me to go as a loan, and I'd have to come back and work for 3 years on contract. So I said, great, I'll do that. It's a huge amount of money. So again, those things won't happen now, principal, I don't think. I came in at a good time, I think. Wouldn't do it. So it really made an impact. I was able to get into the Eastman Dental Institute. This gentleman here is known to some persons who went to the Eastman, Dr. Derek Setchell. He really became my mentor. He really was. He was the head of department. He was a very scary gentleman. He did not accept anything less than perfection. So, you know, I was already working as a dentist probably a few years, 7 years, and you think what you do is good enough. And he would see it and he said, what rubbish is this? Is this what you've learned? You know, and I said, well, I went to Guy's. It wasn't in Trinidad I learned this. I went to a London hospital. Then you would do wax-ups on your models, and he would come and look, what is this? This is looking like a bunch of coconuts, not teeth. And these are the types of persons we had to deal with. Very not student-friendly. They'd pick it up, throw it into the bin. So I say this for my dental students because I think we're very student-friendly now. We're very nice. We don't rough you up in that way. But I have to say, it's like going to boot camp when we went to the Eastman. It really was one of those really rough, challenging times. At the end of the first week, the staff there said, well, you're in a group of 12 men. I'm the only female in my cohort. You're going to be running to the washroom in tears by the end of the first week. And I said to myself, no, I'm not. I'm going to cry at home. I'm not going to cry at work because this is just going to let down the whole, you know, female side. So really, I got through that, and he was an excellent teacher. And what he did was, I was only supposed to stay for 1 year. He encouraged me to stay and do my fellowship training, and also hired me as a lecturer to teach postgraduate students at the Eastman. So I'm very grateful. Great guy, lots of great training out from Derek. And I know some people are quite familiar with him. So that was the clinical aspect, which I really enjoyed. Again, I'm not so sure I enjoyed the research aspect. So I know I've gotten the professorship due to research, but it's not my first love in that way. And Christine knows this, she's laughing at me, right? And so again at Eastman, I had to do a project. I chose a project because I had already worked in the material science, so I thought this was safe for me to do. I did not know the person who I was going to work with was now the head of the department, and was actually persons who were formulating the dental materials at the time in the UK. So he was having a lot of projects and wanted to work on experimental formulations. So it was a great experience, but it was a difficult one. So I spent my time looking at these glass ionomer cements, wanted to apply different techniques that heat and pressure to see if we could improve the strength of it. But as I may have told you before, the plus side with the glass ionomer cements is that it releases fluoride. So we don't want to actually have a benefit being reduced when we make adjustments in the formulation. So I had to make these cylindrical specimens, which are how dental material science goes. Sit in this basement with these big machines that are used for engineering and smash things all day long and see how strong they are, and then measure things with fluoride meters to see how much fluoride. Summertime in a basement in London, very frustrating, and I just wondered what on earth was I doing here? How could I continue to do this? But I carried on and we did it. We found some results. So the experimental group, I'm apologizing for the slides kind of not looking too crisp because it's pretty crisp on the screen, but it's a bit washed out on the presentation, so I apologize. And we have control groups in yellow. We have compressive strengths, but the formulation for the experimental one, we did not find it improving, so it was very variable. The formulation for the marketed one did improve. But unfortunately, what we're looking for is the fluoride release, so that got reduced a lot with the marketed one, and the formulation one, it didn't show any significant improvement. So again, the results may not be great. It's one that contributes to the literature, But for me, at that point, it was really looking at that training and research methodology, which I was so grateful for to have to come through, and we were able to get it published. And again, Prof. Walker to thank for that one. So I did quite a bit of research on dental materials, and we did another one at the school, this time looking at what we're going to fill into the cavities of some of these root canal treated teeth, and we were comparing a fairly temporary material with two permanent ones. Again, the glass enema, but this other permanent one, again, was a new material that had come out onto the market, which was trying to capture the best of both worlds of the composites and the glass animals. Oops. So we had experimental groups, control groups. What did we find? So we have a tooth that's been rendered transparent, and we put it into a black dye, and it's leaking all at the top. So what we found is actually the newer material was really, really poor. And again, contributed to the fact that that material now, even with improved formulations, we're only using it now really in areas that can't support any large stress or load, and in a lot of pediatric teeth. Right? So fair amount of dental materials work in the lab, and to be honest with you, I kind of like that. It's nice and controllable. I got involved in use of xylitol in the next study with my very good friend, Professor Christine Carrington. So I think she got dragged into it after, but who really came up with the master plan for this particular research was Professor Jonas Adai. He was the head of department in preclinical and Professor of Physiology, I think, yes. So I had gone to a research conference and presented my research, and he came up to me and he was just chatting, and we need to do some work. You're a dentist, you know. I'm a physiologist. Let's look at something in saliva. And I thought, okay, let's do that. Then he said, let's look at something with, you know, xylitol and chewing gum. Okay, we're going to do this. And I'm thinking, I don't know where this is going, okay? But funny enough, sometimes you have to be open to research ideas. So we developed the idea. Again, we got campus research funding because he said, let's ask Christine what we can do when we're looking at the microbiome. And I think at that point, you were linking with a lab in the US. So you had not developed the techniques yet to look at anything with gene sequencing. So we wanted to look really at the oral microbiome. Generally, the human microbiome, we have areas all over that will have their own microbial sort of composition. And we mostly live harmoniously with our microbiome until some imbalance occurs. And when this imbalance occurs, then we get this dysbiosis, or you have problems now developing. So that's when pathology starts. So that's the bad news. So in terms of my research, I'm looking at dental decay. So we know from earlier studies that are using what we call culture-based approaches, where you're actually culturing bacteria on a plate. We know there's an association. This is probably the only bacteria's name I'll call out, okay? Mutans streptococci, classic, for dental decay. But when you look at it in one sample, you'll have to culture just 1, 2, or 3 bacteria that we're looking for. And just linking up and having a talk with, you know, persons in my faculty, not necessarily in dental school, we were able to actually look at the literature, and I realized this is a huge new area at the time that was coming out. And the oral microbiome was now being sort of thought to be interesting. And we could we could actually do it without culturing and do via gene sequencing, this particular type of gene sequencing of the bacteria. So in one sample, we can actually find out a lot of different microbes. It is going to influence the decay, maybe it's not, we're not sure, but we're able to generate now a lot more data. So that gives us an insight into what our oral microbiome will be. So for some reason, rather than just looking at it simply, looking at a healthy person and a person maybe with some disease, we decided we were going to do a human intervention study. So if you realize we're doing human intervention now, we have to get groups of people where we can actually have controlled, so we can then assess whatever we give them, and in this case, the xylitol or the sorbitol chewing gums, we will actually be seeing the effect of those rather than something else they're taking. So we have to match the groups up pretty well, and a lot of exclusion criteria to be able to look at it. So this was a really interesting study for me. It sort of challenged me in terms of what I was doing in research and having international collaboration and cross-collaboration. So I did again, the work related to getting the patients in, examining them, getting their histories, consent. And then we had to assign the two groups and assign one would choose xylitol gum, one would choose sorbitol gum. The groups did not know what the gum was, so it was blinded by the persons who were taking it, the subjects, and also double blind because the clinicians did not know either. So there would be no chance of any sort of knowledge of what was going on. We had them go through a washout period for 4 weeks. So we know we sort of cleared of anything they've been using, and then a 3-week treatment period. And we've taken samples of saliva and plaque before and after treatment. How saliva is collected, I've just put it up just for interest. We have to get patients to chew onto some paraffin wax and collect saliva, and then we got it pipetted into some cryotubes. And then we also wanted to collect the plaque to a very standardized, rigid protocol as well, and get the plaque into these buffers, and then get it into the negative 70 degrees. And when we were ready for shipping for DNA extraction and sequencing, we were able to send it to the lab that we were collaborating with. So, not meant for you to read it at all. It's actually just meant for you to say tons of statistical analyses were done, right? And what I was impressed with finding out doing research in this area is that now they have the human oral microbiome database. So what we were finding out was contributing to that. The way it's measured, so this results for that particular group showed that I had actually gotten the groups fairly well matched because there was no significant difference between the groups themselves in terms of age, gender, and the DMFT. And again, the results are just to illustrate how complex these things are in terms of the diversity in the human oral microbiome. So this really illustrates what we have in terms of everything in red is plaque, so some are more abundant in plaque. Anything in blue is saliva, so some are more abundant in saliva. And then looking at the diversity between plaque and saliva. So that was a huge amount of data generated. But what I was interested in, of course, was whether or not the xylitol or the sorbitol gum actually had an effect on these bacteria that cause caries, or had an effect on the bacteria that protected us from caries or dental decay. What we found in the short-term study was that it did not affect the composition and plaque. There was a limited effect on the saliva. But as a side finding, and this was the beauty of using this type of gene sequencing, is what we found was the sorbitol actually affected some bacteria that were associated with gum disease and periodontitis. So sometimes when you're looking for research in this area, you're not finding what you think you're going to find. You find something else, but it may be significant. So I'm continuing work with Professor Carrington in this area, and we're actually looking at patients now with periodontitis and patients with implants and patients who are developing some peri-implantitis as well. So a great area to continue in, but it's one of those areas that I can't say it's my comfort zone. It really is a challenge. So, what do they say? When you have blue skies and sunshine, everything goes well, but you need clouds and rain to make things grow sometimes, yeah? So life is not just about, blue skies and sunshine. I would like it to be like that, I agree, but this is the old dental school. Well, it's still there. This is what we're working on top at Mount Hope. We have the new dental building that was set up. 2015, we did a sword turning ceremony for it, and we opened, I think, just before 2020, January. And then COVID hit us in March 2020, and the building was shut for quite a while. So we're existing in 2 structures, and challenging place to be. It's not easy at all, but very, very fulfilling, I think, because of the patients that we treat. So we do see patients coming in from really what we call the lower socioeconomic areas, patients who can't afford to go anywhere else. So we have a huge pool of patients that are really great learning material for all the dental students that have gone through. All right, I just put that in as a little break to remind me to probably sip water. So I'll just have a quick sip. What that did, thanks, what that did coming back the second time to Trinidad was, when I was in London, the cases that we were treating were what I thought was very different. We were a referral center, so we were treating quite a lot of patients with what we call advanced tooth wear. And I thought to myself, I've been in Trinidad nearly 6-7 years, and did we have this in Trinidad? I couldn't imagine that I'd missed something. And I was wondering when I came back, did we really have this problem? So switching from the dental decay, first thing we did working with my colleagues who were back in the department and Andrew Eder, who's in London, was looking really at a prevalence survey for what we call tooth wear. And tooth wear, essentially, you may be familiar or not, if you have teeth wearing due to tooth-to-tooth contact, we call it attrition. If we have tooth wear due to physical contact with another object like a toothbrush, we call it abrasion. And if we have it due to some acid, but not from oral bacteria, we call it erosion. So we have a lot of sources for this, and I think this is really a lot of the messages I want to get out to in the public. We get the acid from maybe intrinsic sources, which is basically a stomach acid. And you can have it coming up in different conditions, such as reflux disease. Patients may have eating disorders, and also patients with alcoholism if they're regurgitating a lot or maybe vomiting due to morning sickness. So anything bringing up that acid into your oral cavity can have an effect on the teeth. And also the extrinsic sources, the sources that come from outside of the body, dietary erosion due to fruits or drinks, sodas, wine, pickles, vinegar dressings, preservatives, lovely things that we like to eat, chow, right? So all the things that we think are great for us, what happens? It can have a really bad effect on our tooth tissues. So we really have to be aware of it. The study that we did right away as soon as I came back was looking at tooth wear, and we used an index that the UK Dental Health Survey used at the time so that we'd be able to compare ourselves to the UK, because as I say, I wasn't sure why this problem was so widespread in the UK and did we have this problem in Trinidad. And actually what we found with the survey and the clinical examination is that essentially 72% of patients had tooth wear. And more than that, 16% had moderate, 4% had severe. So really 20% were in the moderate to severe category. And that was twice the amount that the UK population had. So for Trinidad and our diet, we really had quite a lot of tooth wear. What were they associated with? They associated with age. We could expect that. As older you get, you may have more tooth wear, but also reflux parafunction is when people grind their teeth. Weekly consumption of citrus fruits and soft drinks, daily consumption of alcohol, and a vegetarian diet. And again, everybody's pushing a plant-based diet and a vegetarian diet, but it does actually do a lot of wear on your teeth. So one thing I wanted to do as well was highlight to the medical colleagues. So I wanted to publish in the West Indian Medical Journal, and I did this with one of our teaching assistants at the time, dental erosion and linking it with the medical conditions. I've mentioned these before, your reflux, maybe eating disorders, but also any condition that could actually lower your salivary flow is going to have an impact on erosion. So patients who have autoimmune disease, patients who may have had radiation treatment for head and neck cancers, patients that are on medications for a variety of conditions that cause low salivary flow, this has a big impact. And again, I think for medical colleagues and dental colleagues, what we really want is to be working much closer together so that we could have really the best outcome for our patients, right? So another study I did with Dr. Sharma, as I say, him and I are probably the only Trinidadians who go way back, and he wanted to look at the pH of beverages and the most commonly used ones in Trinidad. So he did a survey of which were the common ones, top 2 in each category, and then looking at the pHs. So apparently the Stag and the White Oak people buy the most, right? It's not Carib and something else. What does it do in terms of pH? Coca-Cola and Sprite, we know low pH. Once the numbers are low, things are more acidic. The fruit drinks, again in the low areas. The water is supposed to be a little more neutral than that, but even they have some lower than 5. And then the alcoholic beverages are low down. So again, really to highlight to the public, really, the things that some of these are having on your teeth. I don't have a lot of dentists in the audience, so I didn't want to say that toothwear is only related to pH, because we know a little more. So toothwear is also related to something called titratable acidity, and that's basically the amount of alkali that you would need to neutralize within that acid. And to point out, really, a lot of the energy drinks that we have, they have very high titratable acidity and really higher risk for dental erosion. So the energy drinks are not only problems in terms of having high caffeine, so they can have some cardiac effects on you, they have a lot of erosive potential as well. I'm going to run through some of them because I know the data might be getting a bit heavy. But one of the things, particularly for dentists, we're always concerned about when we do our fillings, are they going to stay in? And the patients hate it if you put a filling in and the filling pops out. So one of these areas in particular, which is around the neck of your teeth, near the gums, we call these non-carious cervical lesions. So a lot of toothwear patients have this, and we wanted to know how much. This is another big study. We did about 156 patients. 62% had these lesions. And again, they're significantly associated with heartburn reflux and significantly correlated with medium and hard toothbrushes. So again, this is the data and the evidence we need to tell people when you're using soft toothbrushes. Now, even the soft toothbrushes are going to cause issues, but at least that's better than the medium and the hard. So again, we have evidence, a big study. A lot of the toothwear cases come in with sensitive teeth. Your patients are always very commonly complaining. 300 patients, and over 50% of them reporting sensitivity and associated with tooth grinding, consumption of citrus fruits daily, vomiting. We're always telling people, you're going to consume fruits daily, it's a good thing. Absolutely. So I can't stop you, but perhaps maybe you're aware why things are becoming more sensitive for you. Toothwear, again, is a big area in terms of management. So simple things we can give in terms of advice for the patients. Sometimes we may refer to the medical practitioners if they don't know they've had heartburn or reflux. We can give diet advice. There's a huge amount of toothpaste out there for sensitivity, and we can use our soft toothbrushes. But in terms of the area that I really work on is more the active care and a huge amount of restorative dentistry, from simple restorations to some of the more advanced work. And the composite restorations that we use are really tooth colored, but there are a number of newer products out there that we looked at and in terms of investigated. So a lot of the clinical work we've done, this would be toothwear, but not due to trauma or falling down. Very simple work you can do to enhance a patient's smile. And some of the more newer materials, again, published and following up these patients nearly a year or 11 months to actually see. Again, apologies for this slide. It's looking very washed out. You're supposed to see very small variations in pink here, and it probably is looking just all pink. I'll put this up for the dentist just to remind us all the issues and problems we have with these patients in terms of care, but to go to some of the more advanced treatment for full mouth rehabilitation cases. So as I said, at the dental school, our patients are really not not in a position to have maybe the full ideal care that we want to provide for them. We want to do all this fancy work, a whole set of crowns and bridges, and they simply can't afford it. Because people can't afford care doesn't mean they shouldn't receive care and the highest quality care that we can give. So patients come in and we have to find a way and figure it out. So this gentleman was referred to me. Again, real problems. Everything is broken down. His teeth are discolored. He's worried he's going to lose teeth. He's been to a few practitioners and he actually couldn't get care. So he was very worried by the time he came up to the school. We said, okay, let's try and get things done for you. Let's see what we can do. Oops. And we were able to bond onto his teeth using the composite. But before that, what's this up here? Apple cider vinegar. Great. A lot of people use it for health reasons. And it does a huge, huge amount of damage on the teeth. So actually, this is what he was doing. He had heartburn. What he was calling heartburn was reflux, and he was using the apple cider vinegar, and this was working wonders for him, but stripping his teeth away. So we really have to work with our patients and our medical colleagues. So I referred him to the doctors. Well, I said, look, let's get you on some Nexium or something, and we got to see how we could restore your mouth. But the traditional approach to all of this would have been really putting in full mouth crowns. So again, I said, let's try and work what we can do. For the dentists out there, I know it's showing jumping back and forth, but I would have done all the study models, the articulator, the diagnostic wax up, and then form templates. And we use a template index in this case to try and really bond on a lot of composite for him full mouth to give him that protection that he needed. And we were able to restore his smile and get him back to function pretty well. Again, not ideal, wanted nice white crowns. We don't have a lot of space, so we were able to get in some metal onlays for him to stabilize his bite or his occlusion at the back. 6 months later, we're following him up again for the dentist. We're keeping what we call canine guidance in there because we want to make sure our occlusion is okay and protected. And we're able to do a fairly minimal approach, not invasive, very much a preserving approach, and we still managed to improve his aesthetics and his function. And we followed this guy up for a year, and we were able to publish that. So a lot of these cases now would be the restorative technique cases. I'm not going through all, so I've done some on implants, done some with dentures, and I just wanted to review this particular case with you. And she is the lady that we saw right at the beginning. So it's what we call dentinogenesis imperfecta. She has an underlying hereditary defect of her dentine, and it's easily to chip and break away. And we were able to do it. Again, when she was referred in, I had to ask her to bring her mom in because she was so concerned. Her mom lost all her teeth at a very young age. She herself had 2 young children, and she was concerned for them. So we got everybody in, and we were able to help her out. She had a lot of decay, abscesses, root stumps. So we saw her, cleaned her up, and we did essentially what we call bonding on, so very conservative, and a simple acrylic denture as well on the top. I actually made her denture on the lower jaw as well. For the dentists who are out there, you'll see big lingual tori. So it was too painful for her to wear. Now, these dentinogenesis cases are extremely difficult to treat because the teeth are just basically like butter. When you're cutting them, it will just move away. It's just not going to last. So she had agreed on this, that we were going to try and bond as best as we can, but because of the defects, I couldn't even predict the outcome. But you have somebody who needs help, and we're going to actually go through the journey with her, and she was really up for it. She was happy to have anything done. So I ended up doing a bridge here for her, and we were able to get her back to that state. Big improvement. And she was quite happy for about 4 to 5 years. And I know the dentist will know this. You know, when you restore somebody and they were looking like this before, you got them to this level, what happens? Expectations rise. So she was like, Doc, you did this bridge for me. You said everything's going to fall apart. Everything is still there. Can't you do all this nice bridge work for me everywhere? So I was like, okay, I didn't want to do it. But we ended up doing it. and provided her with what turned out to be full mouth rehabilitation. So bridges in all quadrants, crowns on the top and bottom, and we had her, and she had this one tooth that was fine, and again, I had her for about 5 years, and I left it, I didn't want to do it, and it chipped one day, and she said, please crown it, so I ended up doing it for her. So we were able to publish this case because not a lot of the advanced cases, like these types of patients, were treated in this way. They had to have their teeth basically extracted and dentures. So she's actually holding up pretty well. We did it after a 1-year follow-up. And this lady, I have to say, is one of my favorite patients. Treating her 20 years later, her children are now in this university as well. And they were fine. They did not inherit it, but she was this before and this after. And that doesn't happen overnight. And it doesn't even happen in 2 weeks. So sometimes you have to work with your patients. Again, they're not able to afford all the treatment you want at that time. And then you can work through with your cases. But to me, I know I do a lot of research, but really these are the cases that has me fulfilled the most, really having an impact on patients and being able to help them as you go along. So how are we doing for time? Okay, not too bad. Oh, 10 more minutes. I have time. I'm going to close off on this. I do spend a lot of time doing research on dental education, but this particular one I'll pull out only because it has some relevance to what I want to talk about after. But this particular case, I was able to link with a lab in Barts and the London Hospital, Dr. Kevin Seymour. He was one of the external examiners who came down, and we would be chatting about research, in the middle of the exams while we were waiting for maybe having a tea break. So I said, when we had the students, we want to make sure our students are actually performing on par with anybody else in the world, in the States or the UK. So we're teaching the dental students how to prepare the crowns. And these crowns are basically, you want them to stay in the patient's mouth. You don't want to have your patient's crowns failing. We don't know if what we're teaching them is any good. So at that time, I was very driven to really assess competency and make sure that what we were teaching and what they were learning was really benchmarked properly. So we wanted to look at how they prepare these teeth, and these teeth are, in a particular way. We're looking at something in particular called taper. So if you have parallel walls, those are parallel, and if they're converging towards a point, like an Indian teepee tent, that's the taper. I collected about 99 lab specimens. When the students prepare the teeth in the lab, we train them in the lab first, and then we get to train them on the clinic. We want them to know what they're doing in the lab before we let you loose on a patient. And we got about 40 clinical specimens. So just to highlight the process, this is what a tooth looks like if it's prepared for a crown. This is what a normal, traditional analog impression looks like. And we would have to pour this impression up with some stone and make a replica of the patient's mouth. And we're able to fabricate crowns. In this case, this one was gold. This is a porcelain fused to metal crown. And I was concerned about how well the students are preparing these teeth. So we were able to take the specimens up. In those days, believe it or not, when I got a study and travel grant, I would be taking the specimens in my hand luggage up to the London Hospital. And they had a huge lab scanner at the time. So they adapted this engineering machine that is usually 3D coordinate metrology that would normally measure things for engineering. But we're trying to measure free-form surfaces, biological surfaces. So go in there, and I spent a week or two with the technician, but to tell you how long the process was, I had to get back home, and the technician was spending hours scanning these things. Those were the days of dial-up internet, right? So I don't know if you recall that. So very, very long process. And we were able to digitize them into a 3D specimen. Again, I was looking at something fairly simple, trying to assess the walls and the taper. But what they were doing with their specimens, they were connecting it to another piece of equipment, and they were milling crowns out of it. So there were only 3 in the UK at the time that I was working with this group, and they were milling crowns. So crowns were made before by technicians, handmade, and now these crowns are being milled by machines out of some particular type of material. Now, luckily for me, we found that what the students were preparing, even though it was out this ideal norm, 4 to 14 degrees, they still fell into the category of what dental students elsewhere were achieving: UK, Europe, Japan, Egypt, Saudi Arabia, and United States. So it was important for us to really benchmark our students at the UE School of Dentistry to show that they were performing the same way students in other areas. And why I linked that particular project is because the future is here in the dental school. Finally, Prof mentioned it. I know the dentists out there would say the future's been here for a while because you could afford equipment, so it's not something that new. But certainly for us in the school, we're really excited. So we were able to purchase this late last year, and we've started using it. And in terms of what this does, instead of a massive scan in the lab, we now have this intraoral scanner, quite small, and it can actually scan, and it's attached to the computer. One time you get a real-time image of the teeth, and we're able to do what we call CAD/CAM technology, computer-assisted design, computer-assisted machining. And if we had a machine also in our school, we'd be able to get the restoration straight away. So I'm plugging here the principal. When I come, I think we have the funds. We only have to get the paperwork done to purchase. So we can talk about that principle. But what it does is it gives you these lovely images real time, and we're able to make these bridges out of zirconia that's milled. So anything milled means it's being cut and it's subtractive. What's the new thing on the scene, right? So ceramics have been going on for a long time, metal ceramics down to our glass ceramics, 2020 down to zirconia. And of course now everybody's talking about 3D printing. Again, this is the next project I'm on. So I'm on these two projects and we're gonna get it done somehow. Bring it into the School of Dentistry. A very exciting time. So 3D printing is really something that is going to allow the same scanner to connect with this 3D printing machine and produce an object now, fabricating it from an additive technique. And the crowns are going to be ceramic filled polymer crowns. So I know the director of the dental school and other dentists are probably saying, you know, those 3D printed crowns are not going to work well, right? So that's what we want to do research on. We want to really assess them to see if they're going to be up to mark, especially in this population that we have, which we know our diet is really tough going, so we don't know. And I think that's really what I want to evaluate at this point in time. We did have one set come back from an external lab source. So essentially, if we're doing this now, we have to go to an external source. But I really want to bring this into the School of Dentistry. And I think that too can be marketed, because if we have it, we can then sell it to the practitioners out there. I'm just trying to, I know we're in the revenue revolution, right? So that's the exciting part I want to end on. And I don't know how we did for time, but oops. What's behind a smile? So I hope now you have an appreciation what's behind that smile in terms of techniques, in terms of materials. Sometimes you look at your dentist and you wonder what we're doing. You know, we're trying to do a lot, so that's happening. And I want to dedicate this lecture to my parents. I put it at the end because I didn't want to talk about it in the beginning. So my dad is not here, but my mom is here. So she's with us today. And of course, my family, you saw baby bump number 1, so that's him, proud UE alumni, and baby bump number 2, law, faculty of law. And my siblings, cousins, want to thank my family and friends. And I told my friends, I say, you all are like family, so for sure, you know, you all know who you are, right? This is a very busy list. Very busy list, because honestly, I couldn't be here without all of these people, and I probably left people off the list as well. International collaborators within the Faculty of Medical Sciences and UE, huge collaboration, of course, with all my dental school colleagues. And I have to mention some of the directors and past deans who really had a pivotal role that was, you know, really played at certain points. Teaching assistants, I had so many teaching assistants, and some of them are staff in the school now. And, you know, they were tremendous help with a lot of the research that you saw. Dental Council, Trinidad and Tobago, and I'm quite passionate about continuing dental education, so I'm quite involved in the dental associations as well. And so many of them past alumni of the school, but not only that, very proud to say that some of the alumni are in these major roles: Dental Council, Director of the Dental School, Trinidad and Tobago Dental Association. So again, thanks so much to everyone for making the effort to be here tonight, and I hope you know something now about Behind the Smile. Thanks again.
A big thank you to the star of the evening, Professor Rafiq. Your presentation was insightful and inspirational. Thank you so much. So before we start with the question and answer session, please keep your question, because of the time constraint, please keep your questions brief and focused so that we can accommodate as many questions as possible. So the floor is open now for your comments and questions. Anyone would like to begin?
You all awake, right?
Yep.
So on
Professor.
that slide, you had industrial batteries as
External.
What was that about?
Oh yeah, so the batteries actually, the fumes in a factory, that actually has an effect on the workers' teeth. So that's been documented. Also chlorinated pools. So for swimmers who are constantly swimming, the chlorine does all that damage to your teeth as well. Yeah.
Hi, I just wanted to ask, right? Like, I like to chew a lot of gum.
Ah, right, seeing you now. Yeah.
Can chewing gum give you cavities?
Can chewing gum give you, if it's sugar, definitely.
Okay.
So once you have sugar in anything, right? But if you have sugar in the gum, that can contribute to the cavities. So this is why the xylitol gum and the sorbitol gum is what we're recommending. Even though that particular study didn't show a benefit, there is a body of evidence that says that the xylitol and the sorbitol, they're nutritive sweeteners, so they're sugar substitutes, and they can actually enhance, so you can chew your gum with that. What they do also is chewing gum actually promotes salivary flow. So if you actually promote your salivary flow, even if you have bacteria that cause acid, the salivary flow can wash it away, buffer it. So it actually helps you control your cavities or your tooth decay as well. So chewing gum is a good thing if it's sugar-free. Yeah? Oh, Prof.
Professor Harvey.
This might be a hard question.
I like non-vegetarian and you said vegetarian. So in our traditional Indian medicine and stuff, they say that I have to chew the food for like before I swallow.
Correct.
And then that helps in amylase and all this. I mean, there's lots of benefits to that. And then I have to chew all my vegetables. I can't use a straw unless
Correct.
I put it in a blender. But to chew or not to chew?
To chew. To chew. It's like we know things may be bad for us, but you know, some things are necessary, right? We have to chew, we have to masticate, and we have to get it to digest properly.
32 times.
Huh?
32 times chewing, right? Every bite.
Not every bite. But so at least with the acid take is if you do have some type of acidic diet that you're concerned about, you can actually just rinse with water, and that helps. So you rinse out the acid, you get rid of it. Don't brush your teeth, because you'll be brushing your teeth on something that's already primed and soft. So rinsing with water would help, yeah? Just to get rid of the acid. Oh, yeah. Yes. So this is, I can't talk about brand names here, right? But all I can say is some other colleagues of mine, in terms of the flavored waters, they do actually cause a fair amount of erosion. They're quite acidic. So you actually want to get the most neutral waters you can find. Actually, I think Wassa water has not got fluoride in it, right? It doesn't. I hope somebody could confirm that for me. So it doesn't have fluoride. And I know fluoride is a big sort of conversation right now in the US as well. So again, bottled water, sure, but once it's not flavored, yeah?
Yes,
Oh.
Prof. Yeah,
Yes, Prof.
yeah. I have a question. As people get older, there is a lot of gap forms between the teeth,
Yes.
right? Is there any permanent solution of the materials? What you did any
Yes.
research on that one?
So-
Because I always find that they are all temporary, to my knowledge at
Yeah.
least.
So the gaps are forming between the teeth because essentially the gums are shrinking down. So the gums are receding. So your teeth are not losing any material. If we go ahead, we can actually bond composite to it. So we can use some of the materials I showed, but they have to be done in such a way where you can still maintain your periodontal health or your gum health. So that's the difficulty. If it's done badly, you'll be in problems, yeah? But if you have it and it's cleansable, there's no issue with it. It's only if it's causing you problems like the aesthetics you don't like, or if it's causing you sensitivity. But you can use these materials we spoke about, tooth-colored materials, and bond onto it. Oh,
Okay, so just taking us back to the fluoride. When you say Wassa water doesn't have fluoride, you mean that you think they don't add fluoride?
they
But
don't add.
some, as far as I know, there are some soils that naturally have some fluoride in it. So do you know if our water has natural, I have nothing against
Yeah.
fluoride, but does it have natural fluoride in it? Or 'cause sometimes people don't add because it's already there?
Yeah, it's,
you know.
it's not added,
Yeah.
but there is some naturally occurring fluoride
Right,
in the
okay.
water, yeah.
All right,
But I
thank you.
can't tell you what areas that happens in.
Okay.
Yeah, I don't know if any of the dentists know. Did anybody? We have got a lot of dentists. Anybody did work on it? No? Something we need to find out about. Okay. Prof. Basso. Thank you, Prof. Thank you.
You want to keep the early signs of your, the part of being a dentist. You mentioned about the microbiome and abnormality in the microbiome with medical conditions. Now, as a gynecologist, one of the things that we are particularly concerned about is periodontal disease and preterm labor.
Yeah. Periodontal, so I think we've done some research even to look at periodontal health with patients who have gestational diabetes as well. So because we have periodontal health linked with diabetes. So one of the studies I think we did with Prof. Luxing was looking at the gestational diabetes, but in that cohort in Trinidad, we didn't find any difference in their periodontal health, whether they had gestational diabetes or non-gestational diabetes. But I think that link with periodontitis now, with so many systemic diseases, is growing, well, it's quite strong. It's good evidence for it. So besides the diabetes, atherosclerosis, so they are now looking at the atherosclerosis is when the arteries actually become formed with plaque. And I think what they're showing now is that even if you get periodontal cleanings, that can have an effect on the cardiac markers. So the cleaning is not just for us in your mouth, in your oral cavity. It actually can affect your blood glucose levels. If you have severe periodontitis and you have the periodontal therapy, it can affect the cardiac markers. And the other thing is Alzheimer's disease now, I think. They're linking it, again, they're not saying it's a cause, but what they found with the plaques in your brain, which is amyloid beta protein, they find porphyromonas gingivalis, P. gingivalis, actually present. So now there's a link with, if you're actually looking after your teeth properly, the association right now, I'm not sure the Alzheimer's, but the association is showing that a lot of those patients are very poor periodontal health. Yeah? So the importance of you just going to the dentist thinking it's seemingly a very simple cleaning is actually quite high importance now, I think. Yeah? Thanks, Prof.
Hi, I'm just going to go back to the fluoride. Just as in natural waters, fluoride's pretty low naturally. But if you're interested in looking at fluoride in Trinidad, I will volunteer to
Great,
assist.
thank you, Dr. Beckles.
Great lecture, Prof. Rafiq.
Thank you.
I was just curious, with the restorative materials that you typically use, how resistant are they to things such as acid? For example, do you have to fix what you restore on a regular basis? How long do these materials typically last?
Yeah, they're pretty good now. I must say, coming through the amount of research that we've done, the composites materials, you're talking about, as a cavity, small amounts, they can last 10 to 15 years. If we're talking about a lot of the bonding that I was showing with these big cases, we would predict like 5 years to 7 years. So we may get problems with discoloration, we may get things chipping and breaking, but it's very easy to add on to it, so you don't lose anything. The acidic attack too, there's a lot of research on that. So of course there's some damage to it in terms of the solubility of the material, but it's not something that's going to dissolve in a very short space of time, but it does actually affect the porosity of the material. So the surface of it tends to break down. And this is why with the kind of diets that we have, it really has an effect on those materials. Hence the importance of getting things really checked constantly, so they don't deteriorate. Glass enema is a great one in the oral cavity, because even if it's there, it's actually releasing fluoride, so it's quite beneficial to the tooth. The problem with that material, it's not as aesthetic, so sometimes patients don't accept it. And we can't put them in those load-bearing areas because it's not as strong. The crowns and the bridges, though, the zirconia-type materials, pretty tough and inert, so things tend to not affect those as well. The acid can't do any damage virtually to it. We have to do quite a lot of damage if we want to get those to etch. Yeah? So we use powerful etching agents in a lab if we want to actually etch the crown. Yeah?
We have a question, one question.
Thank you, Prof. Rafiq. When I think about carbon excellence, I see it in front of me with this presentation. Thank you so much for that.
Thank you.
The question I had to do with public health outreach and how this might translate to communities and getting them to buy into such things as drinking less Coca-Cola, for example. You know that alcoholism is on the rise in Trinidad. So where do you see this research going in terms of public health policies? Have you had any contact with Ministry of Health officials as it concerns translating this research into actionable outreach?
Nice question. Public health is not my strong point, right? But I see myself as a restorative dentist, so when we have these issues, I'm treating one patient at a time, and I'm getting the message out to that patient. But absolutely, I take your point that, as a school, we could be really promoting these public health messages. The companies tend to do it better than we do. The big companies, Colgate, will be pushing it, but for us to actually get out there, I think it's a good idea for us to actually push that outreach. When we do the outreach, as I say, we do it with schools. We tend to do it with persons who approach us. But I don't think we've really approached the ministry in terms of having the messages put out. The Dental Association, yes, but not the university part. But I think that's something that we could look at. I think we work in silos, and we don't tend to get simple, big messages out there. Yeah, so good comment. I'll put that out to the public health people in the dental school.
Hi, so you specialize in restorative dentistry. I wanted to know, what role do other specialties play in your line of work?
Yeah, great question. We have to work so closely with so many other specialists. The orthodontists, a lot of the things that we do in terms of providing bridges and dentures, we always have to consult the orthodontist because sometimes instead of just fixing the teeth as they are, we want to move the teeth around. Another big area, I didn't present that research, the cancer patients. So obviously when people have had, cancer of the jaw, upper and lower, they have big defects, and we need to actually, restore those defects with either a denture or a bridge. Now we're looking at implants. So there was a couple of cases that I had, but it didn't fall into the theme of this evening, but we have to work quite a lot with other specialists. Yes, thanks for that question. Yeah.
Any more questions? That's it. Thank you so much for your questions and engagement. Thank you, Prof.
Great. Thank you very much. Thank you.
Thank you, Dr. Gunjan Aswal. He's a member of the Open Lecture Committee and a colleague of Professor Rafiq from the School of Dentistry in the Faculty of Medical Sciences. So we are coming to an end of this evening's proceedings, but before we end, just some very important acknowledgements. Principal Antoine, thank you. I don't think I need to add anything more for that, for the interest you take and time from your very busy schedule to be here and supporting the work of this committee, even as you lead the institution to greater heights. One could only imagine, right, what it takes to make an event like this happen behind the scenes. And for this, marketing and communications, I've been so blown away by them, right? They do a marvelous work under the leadership of Ms. Chanel Glasgow and her team. They work tirelessly. We also thank the School of Graduate Studies and Research under Director Professor Duresami Saranovana. I'll call you just Professor Sarah, right? For their administrative support through Mr. Joel Jordan. And of course, none of this would be possible without the assistance of the good folks of TLC, the Campus Security and Department of Facilities Management, and of course, I didn't forget you all, right? My lovely audience, we're deeply interested. And of course, we're not done yet. We always save the best for last. The star of the evening, the trailblazer, the absolutely brilliant, right, Professor Risha Rafiq, who definitely brought a smile to all our faces with her very interesting, inspiring, and insightful lecture. So Risha, I was in school with her, right? I won't tell you how much before or after. Right? So we have a small token of appreciation as a little memento for this evening to present to you. And for that, we invite our esteemed principal to make the presentation, Professor Belle Antoine. Right, so two absolutely brilliant professors in our midst, and I have to say it, I'm just so proud, fellow woman in science professors. So it was a big evening for all of us here. Yay, big up for Risha. So it's been said that if eyes are the windows to the soul, then the smile is a mirror of the heart. So we leave you with smiles on your face and a happy heart, leaving you hungry. Are you hungry? Yeah, we kick that, right, for more. So in keeping with that theme, just letting you know, there are some light snacks for you on your way out, and I'm so pleased to say we have water and not juice, right? Nor Coke, right? So this is actually my last lecture as chair of the Open Lectures Committee. So for one last time, I say, in the words of the great Porky Pig, that's all, folks. I bid you good night and safe journey home.